So please bear with us because we are not having a break. We're going on to the next session, which is Innovation in Modeling and Integrating Information. And Daryl Abernathy from FDA is going to moderate this session. So let's go ahead and move right into it.
If we can go ahead and get switched out, I think we'll have a full agenda, and I know that by the end of the time, people will be ready to go. And thanks so much for the quick name change. Good. So I think that this session's really well timed because this is a kind of, well, how do you really do this? These very diverse sorts of data streams. How can they be brought together in a way that they leverage the maximum amount of information that you have some confidence in? So to that end, let's get right to it. The first speaker is Brian Alexander, and he's going to talk about statistical modeling for efficient and adaptive trial design. Brian?
Thanks very much for the opportunity. I'm going to mostly be talking about how to incorporate the data that's being developed during a clinical trial, but these frameworks can kind of be used to incorporate data that has been generated either before the clinical trial or preclinical work. So I normally put this slide up just to kind of, this has come up a couple times, and this isn't a perfect continuum or anything like that, but in terms of generating the kinds of data that we are looking for, it really matters what you're trying to accomplish, and I've heard that before, and I can't stress that enough. What I'll be talking about in terms of an adaptively randomized clinical trial for patients with glioblastoma is in this area where we're trying to find out if a drug is doing of something of value to a patient. So in glioblastoma, we have a lot of signals that are in either preclinical data or early phase clinical trials, like in a response rate, but we haven't had anything that's kind of been useful in phase 3 testing until recently. So some of the potential design issues that we've had in brain tumors are not unique to brain tumors, but we use endpoints that aren't necessarily relevant. And we can use overall survival because these patients do, unfortunately, very poorly. We don't have effective controls. We have a lot of downtime between studies, which is, as a clinician, is really kind of depressing because when you have a patient comes in with an incurable tumor and you can't enroll them on a trial, not only are we not generating any information from the patient, but you're also not giving them a chance for anything better. So, a couple solutions to this that have been talked before are these master protocols, and that's one of the kind of logistic but really big benefits of the trials are there's not really a downtime between trials if you can just add the arms and drop them and not have a trial close and not be available for 6 months. And also for, in lots of disease sites, but, TCGA, the first genomic data that was reported out of TCGA was on glioblastoma, and so we have this wealth of genomic knowledge and now multiplexed use of genomic data. But you can do that to look for one biomarker, but then you have all this other information. So, what kind of frameworks can you design to utilize that information more efficiently? So this is our kind of trial that we put together, which is called Insight. It takes newly diagnosed GBM patients and does kind of sequencing and copy number analysis, and then has an adaptive randomization procedure, which I'll talk a little bit about. But importantly, its endpoint is overall survival, and this, which I'll talk about later, this time to progression and survival post-progression modeling factors into some of the randomization, but not really used in the analysis of the trial. So just take a brief adaptive trials. It's kind of used very broadly, but I'll be talking about it as a way of using accumulating data to decide how to modify the study, but in a pre-specified manner. You can't just kind of do whatever you want. You can have everything from adaptive randomization to dropping arms or even early looks, surrogate endpoints. I'll talk a little bit about Bayesian design. We used a Bayesian approach, and I won't get too into the weeds on the likelihood principle, but just to say that from a clinical trial, saying that the data is really the only important thing, not the actual design of the trial. And this is a good example from a review Don Barry wrote in 2006. And he said to consider like an experiment that's testing the hypothesis that some value is 35%. So is a control rate, is it a weighted coin or something like that? But it's a kind of binomial distribution. 35% is what we're testing. And this is actually the trial you get. You get 7 successes and 3 failures in that order. And the way you would kind of interpret this in a frequentist approach would be to say, you know, given that we're testing 35%, what's the likelihood that I would have gotten 7 or anything more extreme? And you add these all up and you get your p-value. And I think he used this example to show the next point, which is that if we would have just designed the trial to proceed until there was 3 failures, we've got a different p-value. And so just to show that p-value is very linked to how you design a trial. So it's less flexible. And so, you know, this speaks a little bit to one of the questions that came up earlier, is how do we quantify kind of uncertainty? And this is kind of it in a Bayesian approach, which is, the upper left corner is the kind of uniform prior, which means we don't know anything. This is a probability distribution of a parameter. We don't know anything, and that's controversial. And then after you get 1 success, you know you can't have a 0 effect size, and you can have 1. So the curve starts kind of forming. The center starts finding where it is, and it narrows, and that's kind of the measure of uncertainty. And you can kind of look at different measures of uncertainty. You know, I won't get too much into this, but we will look at the area under the curve to the left of a certain point. So if you had a parameter estimate, like let's say the top right, and you took all the area to the curve to the left of it, you'd have a different value than if it was a curve that was a little bit more constrained. So how do we incorporate that data? We actually did a simulation where we took actual clinical trial data from 4 separate phase 2 trials and pretended that it was a big adaptively randomized trial. And this was our randomization parameter. And basically it just says that the probability of being randomized to any specific arm is conditional on the probability that the arm is doing better than the other arms. That's it. We included this. This was a kind of a design choice, which just meant that we kept the control arm the same size as the arm that's doing the best to preserve kind of the possibility of doing a frequentist analysis at the end. So this came up before, where, you know, combining frequentist and Bayesian approaches. We used the Bayesian approach as kind of the adaptive randomization, and then preserve the ability at the end to do a frequentist comparison. And this is kind of what one simulation of this simple trial looks like. And basically, this is the end of it. This is the probability distribution of where we think the relative risk is versus control. For each of the arms. So this red arm would be doing kind of worse than control. The blue arm is doing better than control. Green arm somewhere in between. And these are the associated Kaplan-Meier curves. And our adaptive randomization algorithm kind of translates into these randomization probabilities. And then the sample size kind of changes during the course of the trial. And hopefully, can you click on that? We'll start from the beginning when you don't know as much. And you can kind of see how as the information generates, you kind of get a better sense of where the probability distribution lies amongst the relative risks, and that really informs the randomization probability, such that the red arm that's doing bad isn't having anybody randomized to it anymore, and the sample size stays constant. And so this is what one simulation would look like, but again, this is all probabilistic, so this is just one, so you have to run it a bunch of times. Let's say doing the code is time intensive, but running the simulations is obviously just computational. But I think people that aren't used to this ask, you know, we say we're going to run 1,000 simulations. It's like, is that going to take 3 weeks? Like, yeah. Yeah, it's going to be very difficult. So this is just from our paper on this specific simple model. And really, it looks at 4 different simulations. And just as more patients are enrolled, you know, each one of these starting points was different, but it finds kind of the signal that we kind of assumed. And this over here just shows that it randomizes the arm that we said was working better at a hazard ratio of 0.6, the same as control, and less people to the arms that aren't working. So this is really computationally intensive to do the code, and like was brought up before, there's no kind of off-the-shelf software. And it takes a lot of time to revise the software if we, you know, take this and we don't like the simulation, or we make different design choices and do it. So you know, we were supported by a Burroughs Wellcome Grant, and we got this was really the only way we could develop the statistical software to do this trial. We do want to get information about overall survival quicker, but we don't know whether any of the kind of auxiliary endpoints before overall survival necessarily predict overall survival for GBM. And we have some prior information on it, but each kind of therapy may be different. So we developed this longitudinal model, which is trying to bring information to bear about overall survival without having overall survival. So basically, it does like this. So if these are 4 arms of the trial, and we just have survival data, the black circles are meant to be the patient has died. So these arms all look like they're doing about the same, and that may not be the case. And so when we have a patient coming in and we want to randomize them, do we just equally randomize them because they all have the same data? So death is binary, but the probability of dying is not. So we calculated kind of a probability distribution of that arm, that group of patients, and what and how well they're doing based on factors that we're looking at during the course of the trial. That may be how well they're doing, whether they've progressed or not, or other kind of response biomarkers that you can look at during the course of the trial. And so we developed this kind of shades of gray model where we can kind of say some arms are doing better than arms without actually having to have that binary event happening. And that informs the adaptive procedure, but not the analysis. And I won't spend too long on this, but we just kind of incorporated this into the randomization. We took 2 different scenarios, one where the progression-free survival was not predicting the overall survival, and the other way, and just showed that this kind of model did somewhere in between if you would have chose overall survival or progression-free survival at the beginning. And just this last point, I made this before in a comment, but it's not really a continuum. We lose all this information in between these stages, and wouldn't it be great if, like, instead of having a prior that was uninformed, whether we can inform it by different kinds of things and start off on the right foot, and also feed back into our preclinical systems and early phase clinical trials and say, are those endpoints relevant? So I'll just say that that trial will probably open in 2016. We're also we've been working with Ann Barker from the National Development Alliance and Don Berry on a global trial for glioblastoma that will hopefully be opening in the next year too, and will be kind of announced and have public discussion on November 12th at the Press Club here in DC. So I just wanted to plug that. So thank you very much.